Good morning, everyone. I'm just letting you know we'll probably wait a few more minutes to let some more participants join before we get started. Good morning, everyone. Thank you so much for joining July's PAFRA Seminar series. Before we get started, I would like to begin by acknowledging the traditional owners of the land on which we meet today, and I would also like to pay my respects to elders past, present, and emerging. And it is my absolute pleasure to introduce Dr. Anne-Marie Maxwell. Dr. Anne-Marie is a research manager at Tresillian Family Care Centres and an adjunct fellow at Macquarie University. And her research focuses on evaluating parenting programs and it has an emphasis on program impact on parental mental health and the parent-child relationship. And Anne-Marie's research is enriched by her background in early childhood education, and she has more than 20 years' experience working in this space. Anne-Marie, I will hand over to you.
Lovely. Thanks so much, Sarah. Just want to double check that you can see my slides. All good there? Excellent. Thank you. So hello, everyone. Thank you for dialing in, and thank you to PAFRA for the opportunity to do this presentation today. I am speaking to you today from beautiful Camaragal land in North Sydney, New South Wales, and I pay respect to the elders of the Camaragal people and extend respect to Aboriginal people who are joining this session today. Sarah has given you given me a very nice introduction, I should say. As she said, I'm research manager at Tresillian Family Care Centres. I have a PhD in psychology, and my PhD project was an evaluation of the Circle of Security parenting program, which is part of what I'm going to speak to you about today. And my research in general focuses on parent-child relationships, particularly parent-child attachment relationships. And as she mentioned as well, even though my PhD is in psychology, I'm not a psychologist. My background's actually in early childhood education. I trained in Australia and then worked for a long time in South Africa as a preschool teacher and director, and then in curriculum development and teacher training before having my own children, returning to Australia, and then working in universal family support. I am wearing a few hats today. So I work primarily with 3 different research teams, predominantly with Tresillian, where we undertake research on child and family health nursing and parent, infant, and early childhood mental health. I am an adjunct fellow at Macquarie University, where I did my PhD and my postdoc, and I am working there with a team that focuses on resilience, particularly in organisational contexts. And my work with them is around resilience in the transition to parenthood and resilience in the child and family health workforce. And then I'm also a member of Healthy Attachment Australia New Zealand, which I'm going to speak to you about a little bit further at the end of this presentation today. And we separately and together undertake research on parent-child attachment relationships again, and have a particular focus on attachment-based interventions, which is what I'm going to be talking to you about today. So in this seminar, I'm going to provide you with a brief overview of attachment theory. I'm going to present a selection of attachment-based interventions with a very short summary of the evidence base for each. I'm going to very briefly talk about the importance of tailoring intervention tools to the target of the intervention and what that might mean for attachment-based interventions, and introduce a relatively new measure, the Composite Caregiving Questionnaire, which is one option for evaluating outcomes from attachment-based interventions. And as I mentioned, I'm going to introduce the work of the Healthy Attachment Australia and New Zealand network. So parenting programs, as I'm sure you will all know, have really taken off as a concept over the past 50 years or so. And they are now widely available in developed countries and increasingly available even in developing countries. And why is this when humans have been parenting for millennia? Well, I think we all know that more is known and understood now about what is good for children and about the impact of different parenting styles and different parenting practices on children than ever before. In fact, there is a bewildering range of advice out there for new parents from a variety of sources. And so what mum or auntie or grandma have to say about how things should be done is not always welcome. And with our increasingly globalised and scattered way of living, mum and auntie and grandma are not always available. So the first parenting programs that were developed were based on behavioural theories like social learning theory and operant conditioning. And these have been the most commonly available parenting programs in Australia. They generally focus on changing children's behaviour by training parents to use strategies like rewards and punishments. There are numerous behavioural parenting programs currently available, but the best known by far would be, locally and internationally, would be Australia's very own Positive Parenting Program, or Triple P. So the main behavioural parenting programs have been extensively researched over decades, and there is substantial evidence for their effectiveness. In general, there is good evidence that these programs can help improve children's behaviour, improve parents' parenting practices, and also parents' and children's sense of well-being. But they are not necessarily suited for all circumstances. Sometimes, often in fact, again, not exclusively, these programs don't suit families with high levels of adversity. They overall tend not to be suitable for parents of babies. They're generally targeted at sort of preschoolers and above. And some parents are uncomfortable with the sort of reward and punishment approach to managing their children's behaviour. And there are definitely other schools of thought that propose that behaviour management techniques don't deal with the intrapersonal factors and some of the interpersonal factors that might underlie problem behaviours. I should flag here quickly that I know the developers of several behavioural parenting programs are working hard to make programs that are suitable for families with high levels of adversity and suitable for babies. So again, it's not an absolute statement, it's a sort of generalization that I was saying back there. So The concerns that I raised and other concerns have led to a recent increase in parenting programs that focus primarily not on fixing children's behaviour, but on improving the parent-child relationship. There's increasing evidence that it's not just the quality of parenting that's important for children's optimal development, but the quality of the parent-child relationship, and that nurturing, supportive, responsive relationships are necessary for the optimal development of babies' brains during their crucial first years of life. Also, a developing understanding that babies' brains are uniquely vulnerable to the effects of adverse environments, and that high quality parent-child relationships have been shown to buffer some of the effects of adversity on child outcomes. So again, a bit of a rider. So increasingly, behavioural parenting programs are including a focus on the development of the parent-child relationship. So again, I'm not saying only attachment-based interventions do that, but most parenting programs that focus on the parent-child relationship as the primary focus of the intervention are based on attachment theory. Attachment theory was born in the 1950s with the work of John Bowlby and Mary Ainsworth, and it's become one of the most influential and heavily researched areas of psychology. Attachment theory proposes that babies are born as social creatures with biologically based attachment behaviours inborn that are designed to keep them close to the adults that they need for their very survival. These behaviours in turn elicit biologically programmed caregiving behaviours from caregivers. And over time, the interplay between the baby's attachment behaviours and the repeated pattern of responses from their caregiver, their primary caregiver, determines the nature of the attachment relationship between that child and primary caregiver. And a child can have different quality of attachment relationships with different caregivers dependent on the nature of that pattern of responses. So attachment theory relates to the human lifespan from the cradle to the grave. The theory proposes that the quality of this foundational parent-baby relationship has implications for the baby's social and emotional development as she or he grows up and their social and emotional functioning. This is partly because the foundational parent-child relationship influences the development in the baby of mental templates, or what are called internal working models in attachment language, of themselves, of others, and of relationships. And that these inform the child's expectations about and their behaviour in future relationships with potential lifelong impact. So while that sounds scary and quite a lot of pressure on parents, it's not a deterministic thing. There are multiple influences. There are buffering opportunities like other quality relationships. There are opportunities for intervention. Some children seem to be differently susceptible, some more susceptible, some less susceptible to that early caregiving environment. But evidence indicates that that kind of pattern of transmission of attachment relationships does happen consistently. There's also room in attachment theory for a little bit of grace. It's not that parents have to get this right all the time, and I will get to that in a minute. Right. So attachment theory and research have direct implications for intervention. According to what's called the attachment transition model, parents' own internal working models of attachment based on their own childhood experiences drive their parenting behaviours, which in turn shape the quality of the child's attachment to the parent. And this transition model suggests 2 points of intervention. Firstly, the parents' internal working models of attachment and of caregiving. These are also known as representations, attachment representations and caregiving representations. I've described briefly what attachment representations are on the previous slide. So they're those internal mental models of the self as worthy of love or not, of others as trustworthy, nurturing or not, and of relationships and how relationships work. Whereas caregiving representations are parents' thoughts and feelings about the child, about themselves as a caregiver and in that caregiving role, and about the relationship between parent and child. The second point of intervention that the transmission model indicates is parenting behaviours. And the other important thing about attachment-based interventions, or the important starting point, is the understanding that the person facilitating the intervention plays a crucial role, providing parents with an experience of having a secure base and a safe haven while they, the parents, explore what can be potentially uncomfortable territory. And this experience of the facilitator giving parents an experience of what we are asking the parents to provide for their child can serve as a corrective attachment experience for parents who have had difficult childhood attachment experiences. So in Australia, by far, the most popular and the most widely available parenting program based on attachment theory is Circle of Security Parenting. While it was developed in the USA, Australia actually leads the world in dissemination of COSP. In brief, COSP is an 8-week program that is designed for parents of children aged 4 months to 6 years. It is generally run in groups, but it can also be run individually. It's a manualised program, and it uses that manualised content and stock video footage and a process of reflection and between session kind of homework for parents to teach parents about attachment. The centerpiece of COSP and the other COS variants that exist is this circle map, that graphic that is on your screen now. So this is basically a visual depiction of attachment theory. It shows the parent, the hands of the parent on the left-hand side, providing the secure base for their child to go out to explore, and showing the hands as the safe haven for the child to come back into when they are dysregulated and need comfort, nurturance, or protection. So thankfully, as I mentioned before, the model and attachment theory are not about parents needing to get it right all the time. The focus is very much on just being good enough. The program acknowledges that parents are human, that relationship ruptures are inevitable, and that they can be repaired. And actually that this process of rupture followed by repair is an important learning opportunity for children. So compared with other programs based on attachment theory, a few of which I'm going to describe later, which are often intense and involve one-on-one treatment with a therapist over a long period of time, COSP has several advantages. So it's widely available in Australia, it's often free, it's suitable for group delivery rather than one-on-one, although as I said, it can be done one-on-one. Sessions, there are 8 sessions, they are 2 hours per session. That's the official guidelines. Some providers do spread the content over more weeks and some spread it over fewer weeks. Training is readily available in person and in Australia and online. It costs about $2,000 and there are no qualification prerequisites for people to be trained as a facilitator. But a major disadvantage is that there is limited evidence for the effectiveness of COSP, in contrast to the strong evidence that I've mentioned for many of the main behavioural parenting programs and for some other attachment-based programs that I'm going to talk about later. Also, interestingly, the child is not present, which is probably the norm for behavioural programs for many of the commonly known ones, but it's unusual for attachment-based interventions, as you'll see when I describe some of the other options. So in an effort to try and help build the evidence base for COSP, My PhD project was, the primary project was a 3-year Australian evaluation of COSP. It was a non-randomized controlled trial. So we had an intervention group and a waitlist control group. We had 256 participants across 4 organisations, 2 in Sydney and 2 in Canberra. The participants were parents of children aged 0 to 72 months, so quite a big age range. And these were parents experiencing various kinds of early parenting difficulties. And given the nature of some of our partner organisations for this research, there were high rates of postnatal depression in this particular cohort. As I said, we had an intervention group and a waitlist control group. So participants in the intervention group completed assessments before and after they participated in COSP, and control group participants completed assessments the same amount of time apart, but both lots of assessments were completed before they started COSP. So looking at the results, we measured a number of outcomes that are components of caregiving representations that I was telling you about earlier. And in the intervention group, when we compared it with the control group, we found statistically significant improvements in 6 areas, well, 5 areas related to caregiving representations and 1 mental health indicator. So we had increases for the intervention group in parental mentalizing. That's the capacity of the parent to hold the child in mind and also to be conscious of their own thoughts and feelings and how that influences behaviour. In parenting self-efficacy in empathy and in affection. And we had decreases in caregiving helplessness, in hostility, and in depression symptoms after COSP. And these improvements were significantly better than any change experienced by the control group. Looking at just the results within the intervention group, we did a little comparison, given that we had parents with a larger than usual group of parents with postnatal depression. We had a look at how their outcomes compared with the rest of the group, because it is known that often parents with depression struggle to engage with parenting programs like this. So pleasingly, we found that improvements in most outcomes were similar on average for all parents who completed COSP in our cohort. And so parents with clinical depression did as well as parents without indicators of clinical depression in most of the outcomes. And they actually did better than their counterparts in 2 areas. They had greater reductions in depression symptoms, as you would expect, given that they had higher symptoms to begin with and therefore more opportunity to reduce those. And they also had greater reductions than the rest of the cohort in hostility. And we had a very small number of fathers in our study, but fathers showed the same patterns of change as mothers. We also did a qualitative study with different participants, where we interviewed a group of parents who had completed COSP and a group of facilitators who were trained to deliver COSP and experienced in doing so. And we found overall that COSP changes the lens through which parents try to understand their children's behaviour, that it promotes empathy for the child, and that it encourages self-compassion and increases parenting confidence. So very much in line with the quantitative findings that we had. So that was all very pleasing, but when I stand back now and look at the current state of evidence for COSP overall, despite its ongoing popularity and despite my PhD research efforts, there is still limited rigorous evidence for the effectiveness of COSP. There have been several randomised controlled trials. These have all been conducted with clinical samples, examining a range of outcomes, and quite a wide range of outcomes, many of which are not direct targets of the intervention. And there have been some positive findings, but there have also been many null findings in those studies. So findings that where there's no change or no difference in what happens for the COSP cohort as opposed to the control group. There has been a recent systematic review of manualised attachment-based interventions, which ranks the COSP interventions collectively in the top 3 for improving the parent-infant relationship. So that's a positive, very recent development. But probably my best estimate at summing up the evidence for the time being would be to say that COSP probably should be best understood at this stage as a universal program rather than as a treatment. It doesn't purport to be a treatment for families undergoing particular challenges or for already problematic attachment relationships. And so perhaps these RCTs that have been conducted with clinical samples are examining the outcomes of the program in a population for whom it hasn't been designed, as well as in some cases examining outcomes that are not direct outcomes or targets of the intervention. So COSP, even though it is very popular in Australia and the best known probably of all the attachment-based interventions here, it's actually one of many parenting programs based on attachment theory. There are other variants of circle of security, as I've mentioned briefly before, most notably circle of security intensive, which was the original therapeutic circle of security program. That's a 20-week program. It's also a group program, but can be run individually. Unlike COSP, which uses stock video footage as part of teaching the concepts, COS Intensive uses individualized video feedback. There is somewhat limited evidence also for the impact of COS Intensive. There are many fewer studies than have been done for COSP. The findings are promising, but again, it's a work in progress. But today I wanted to broaden your horizons a little further than the COS interventions. So I'm going to focus on 3 other attachment-based interventions in the next section of this presentation. And I do so acknowledging that my area of expertise is COSP. That's what the program I'm trained to facilitate, and that's what I've done my own research in. So I am giving you a summary of the evidence for the others that I haven't directly been involved in. And the 3 I've decided to share with you today are attachment and biobehavioral catch-up, or ABC, video feedback intervention to promote positive parenting, or VIP, and parent-child interaction therapy with toddlers, or PCITT. So moving on to ABC. ABC was developed over 25 years ago by Professor Mary Dozier from the University of Delaware in the States. So it is a 10-session home visiting program. The first version was an infant program, and there are now also newborn and early childhood variants of ABC. The main objective of ABC is to help parents reinterpret their child's behaviour and to help parents understand the impact their own attachment experiences have on their capacity to respond sensitively to their child. There are 3 key targets: nurturing the distressed child, following the child's lead, and avoiding harsh or frightening behaviour. There are 2 key features of ABC that set it apart from COSP. One is the use of video feedback. So the facilitators who deliver ABC are called parent coaches, and the parent coaches video the parent and child interacting, and they review this footage with the parents. The other thing that sets it apart is the use of in-the-moment coaching, so direct behavioural coaching from the parent coaches to the parent, and it's while they are in the room with the parent and child. Parent coaches are expected to make at least one comment per minute. So it's quite, if you ever listen to a tape of it or see it happening, it's quite a barrage of commenting, but seems to be very, very effective from the research evidence. And these comments include a description of the observed parent behaviour, a link to the desired parent intervention, for example, nurturance or responsiveness, and a link to the benefits for the child. So a comment might sound something like, it's really nice that you're looking to see what Nisha's pointing at. That's great following of her lead. And that helps Nisha feel seen by you and able to influence her world. So ABC has an impressive evidence base. It was the first attachment-based intervention to be awarded the top evidence rating by the bizarrely named but very influential California Evidence-Based Clearinghouse for Child Welfare. In contrast, COSP is still classified on this database as not able to be rated. This California Clearinghouse is like a database of programs for child welfare populations, and they have their own rating system. So they review and rate the evidence for each of the programs to help guide practitioners and organisations in their choice of programs for their clients. ABC has been investigated using multiple randomised control trials with long-term follow-up. They're currently following up several cohorts who are just at the end of middle childhood and entering adolescence now. And there is evidence for sustained improvements in direct targets like parent sensitivity and responsiveness, in child attachment security, and even in the longer term studies, in some sort of biological indicators of relationship quality and of child functioning, like child cortisol levels and child brain connectivity. ABC also has demonstrated efficacy in families with substantial attachment-related vulnerabilities, including families in the child protection system, infants and toddlers in foster care, and cross-culturally adopted infants. And in fact, ABC was developed for families with these kinds of vulnerabilities. So it's meeting its target in that sense. So there are lots of pros for ABC. The strong evidence base is a huge one. And the fact that they have the longer term indicators of long-term benefits and indicators of change at a biological level is hugely impressive. Also, there are no qualification prerequisites for parent coaches like with COSP, but parents are screened, applicants are screened, not parents, applicants are screened for suitability. But it is very resource intensive. It's the one-on-one delivery and the in-home delivery might be barriers for some clinicians and organisations. And certification, the process is intense and it's expensive. It costs about 7,000 Australian dollars to be fully certified. The initial training is quite brief. It's only 2 days in person or 3 half days online to be trained in one version of ABC, so the infant ABC program, for example. But trainees must be supervised for 6 months. And the process of running it for a family and getting supervision for that family takes about 4 hours per family. So that's including session prep, the visit, and 1.5 hours of supervision. And clinicians need to be supervised with every family to whom they deliver the program across that 6-month period. So that's pretty intense. All right, moving on to VIP. So video feedback intervention to promote positive parenting is the first of 2 attachment-based programs I'm going to talk about that also deliberately and explicitly incorporate elements of social learning theory. I guess actually ABC does as well, given the role of that direct coaching. So VIP was developed by 3 professors at Leiden University in the Netherlands who are huge names in the world of attachment research. It's aimed at caregivers with infants or young children who are aged 0 to 6 years. And like ABC, the program is delivered generally in the parent's home, this time over 6 to 8 2-hour sessions. Again, like ABC, VIP uses video feedback. After an initial introductory session, subsequent sessions begin with recording of an everyday play situation, followed by viewing and discussion of the previous week's video, focusing on the topics for that session. For the infant version, sort of up to 12 months old, the focus is on parents learning to see the world through the eyes of their child and on sensitive parenting behaviour. For toddlers and above, these two things are still a focus. And in addition to that, there's a sensitive discipline component that is added, hence the SD in the little logo that's on the slide there. So in terms of evidence for VIP, surprisingly, VIP is not rated on the California Clearinghouse, but it is rated on the Dutch equivalent as being demonstrably effective. There are 12 RCTs that have been undertaken to date, and these support the efficacy of VIP in a range of populations. And there are evidence for improvements in parent sensitivity, in parenting behaviours, in child attachment security, and child behaviour. I just want to mention briefly too that there's some really exciting Australian research on a variant of VIP that's been adapted for infants who are at risk of autism, either because of family history of autism or because they're showing early signs of autism. If you are interested in reading more about this, I suggest you look up the work of Professor Andrew Whitehouse from the Kids Institute in Perth and the University of WA. One of their recent studies shows that infants randomised to the what's called iBasis VIP intervention had lower odds, statistically significantly lower odds of meeting the diagnostic criteria for autism spectrum disorder at age 3 than those who received usual care. It was a rate of 7% versus 21%. So that's really exciting and an exciting Australian feature in the evidence base for VIP. So pros and cons for VIP, again, it's relatively brief. And the training requirements and costs are moderate in this case. You can do training over 5 days, in person or online. I don't know whether in-person training happens in Australia. I guess it would for that autism-specific variant, but certainly yes, people in Australia could access the online option. And then there's just 6 hours of supervision required prior to a short assessment to be certified. And it costs approximately 4,000 Australian dollars. It's also designed to be culturally sensitive and can be adapted to suit diverse populations, as indicated by that autism-specific version. But like ABC, the one-on-one delivery and the delivery in the home may be barriers and are quite resource intensive, as is the recording, reviewing and preparing of the video snippets, which requires technology and also time. Okay, the third and final additional attachment-based program that I want to share with you today is Parent-Child Interaction Therapy with Toddlers, or PCITT. So you might be familiar with straight PCIT, which is a long-standing, well-established intervention for older children. PCITT is a specially adapted toddler version of PCIT. It was initially developed in Australia, and there are Australians, Jane Kolhoff and Sue Morgan, at least from that list, who are part of the team who've gone on to develop the manualised version of PCITT. This toddler version differs from the original PCIT, firstly in its attachment-related understanding of toddlers' disruptive behaviour as a sign of emotional dysregulation rather than of deliberate attention seeking or part of a coercive cycle. And secondly, in its positioning of the attachment relationship between the parent and child, or caregiver and child, as the vehicle for change. So PCITT combines attachment theory principles with behavioural techniques, for example, using positive reinforcement to encourage positive toddler behaviour, and also social learning theory again, the emphasis on observation and on live coaching and on modelling. It is designed for children aged from 12 months to 3 years who have early onset behavioural issues. The caregiver and the child participate together over 10 to 20 weekly sessions, so it's quite adaptable in terms of the duration of the treatment. Like ABC, it utilises live coaching, but unlike ABC, the practitioner is behind a one-way mirror and the parent wears an earpiece instead of the practitioner being in the interaction with the parent and child. Certification in this one involves 5 days of training followed by fortnightly supervision around at least 2 PCIT cases. It costs just over 3,000 Australian dollars. It is shorter and cheaper if you are already trained in the main PCIT program. Training is run by Karitani, which is Tresillian's kind of partner organisation in New South Wales. In terms of evidence, PCIT is a new program, so there is very limited evidence thus far, and it's also not yet rated on the California Clearinghouse. But there have been several small randomized control trials conducted, and there's emerging RCT evidence for significant improvements in parenting sensitivity, in parenting skills, in parent emotional availability, and in child behaviour, among other outcomes. So looking at pros and cons here, there is promising early evidence of effectiveness, although it's a new program and this is still emerging. The evidence that does exist indicates high levels of parent satisfaction with the program, which is an excellent starting point. And it's suitable for toddlers with challenging behaviours, which can be a difficult cohort to find a suitable intervention for. But again, it's resource intensive because of that one-on-one delivery, because of the technical requirements, and because it can be up to 20 sessions long. So, if you are just stepping into the world of attachment-based interventions, how do you choose a suitable intervention for your clients or for your settings? I'm afraid I don't have time to take you through any kind of decision tree for every possible circumstance. But what I do want to emphasize today is that it's really important to consider these factors. One is the population. So the clients that you are looking to present the group to or run the group for. The age of the child is important, the circumstances of the family, and the presenting issues of the child or parent. A second consideration is around training. What qualification does the clinician or do the clinicians concerned have? Do they have the qualifications for the training that you want to undertake in order to be able to deliver this program? How available is the training? How accessible is it? How affordable is it? And then also the funds and time available for the training, for the supervision, and for program delivery. As you've heard in the 4 programs that I've shared with you today, there's quite a range of requirements in terms of duration, in terms of equipment needed, in terms of location, and in terms of training prerequisites. So important to consider all of those things as you choose. I also want to talk quickly about evaluation. So it might sound obvious that evaluation tools must reflect the targets of the intervention, but it's not always applied. And as I've mentioned before, in a lot of the COS-P studies, there are many outcomes that are assessed in the evaluation of the program that are actually not direct COS-P targets. So if we're remembering that the direct targets of attachment-based interventions are generally caregiving representations, caregiving behaviours, caregiver representation, so attachment and caregiving representations and caregiving behaviour. We need to find measures that assess these. Now, the gold standard tools for measuring attachment and attachment-related constructs are resource-intensive, observational and interview measures like the strange situation procedure and the working model of the child interview. And these intensive measures will always be the gold standards, but they're often not feasible. In some research projects, they're not feasible, and particularly in clinical settings, they're not. So for the COSP study that I did for my PhD project, we set out to develop a relatively brief self-report measure that assesses several key components of parents' caregiving representations. I'm going to go through this very quickly because I'm conscious of the time. So the tool is called the Composite Caregiving Questionnaire. It is a 42-item measure which combines subscales from 4 already validated questionnaires. So it's not a newly developed thing on its own. It uses these pre-validated subscales used with the permission of the individual authors. It has 2 subscales from the tool to measure parenting self-efficacy in empathy and understanding, and self-efficacy in emotion and affection. It uses the hostility subscale from the LSAT study. It uses the mother helpless subscale from the caregiving helplessness questionnaire. And it uses a measure of parent mentalising that was developed by an Australian clinician, Caroline Diamond, called the Diamond Maternal Reflective Functioning Scale. So we have done preliminary validation of the CCQ. Even though the subscales are validated, we need to do validation of them combined in this particular way. And publications reporting that work are in preparation now. And if you're interested, you can contact me to get hold of a copy of the CCQ, or it's also available on the NovoPsych website, which some clinicians might be familiar with, or from Healthy Attachment Australia, New Zealand, which I'm going to tell you a little bit about extremely briefly now. So if you are involved in the delivery of attachment-based interventions, or if you're keen to get involved, I strongly recommend, and this is a shameless plug, that you consider joining Healthy Attachment Australia, New Zealand, or HANDS. So this is a binational network of researchers, practitioners, managers, and policymakers, which was set up to support people using Circle of Security and other attachment-based interventions in Australia and New Zealand, and to also promote the use of attachment-based interventions and also to support rigorous research into these interventions. So HANDS hosts seminars and webinars regularly. And in the past 4 months, we have had both the originator of ABC, Mary Dozier, and one of the originators of VIP, Mariam Bakermans-Cranenberg, delivering webinars for our members on the development and evidence base of their respective interventions. So if you become a member, you get access to those seminars, and you also get access to recordings and or slides from previous presentations, which are available in the members area. Another area in which HANDS provides support is that we have developed a guide to attachment-based interventions. So the 4 interventions that I shared with you today and several others have been put into a document with a summary of how they were developed, who they're aimed for, what they involve in terms of delivery, what they require in terms of training, and a summary of the evidence base for each of them. So that's a really helpful document for when you are going through that process of trying to work out, where do I begin? And that brings me to the end of my presentation. So thank you for your time and your attention. And I've got some links here for each of the organisations relating to their respective attachment-based intervention, and also a link to the HANDS website and my email address if anyone would like to contact me. Thank you.
Emily, that was an amazing presentation. Thank you so much.
My pleasure. Thank you.
About COSP, but also a great overview of different attachment programs. I know it could be a bit difficult to say the program you did your PhD on has mixed evidence.
It's hard, but it's true. It's true. I still love it, I have to say. And I have definitely seen sort of transformation in parents. And I'm still wondering why the evidence is so inconclusive, the actual rigorous evidence. But yeah, I need to be honest that that's the case.
Yeah, and if anyone has any questions, feel free to pop them in the chat or unmute yourself. Maybe I will start with the question, Anne-Marie, just in terms of the differences of the programs. I see a lot of the programs, they are one-on-one and they are
Yeah.
delivered at home. Do you think that might be a factor that's impacting the effectiveness? Um,
Yes. Yeah, I think so. I think it's very difficult to compare a group program with that, the intensity of that one-on-one delivery.
mm,
So I think that is something that sets those other programs apart.
mm,
Um, and I think the in-home delivery is also a real advantage, um, because that's where the relationship happens primarily. And as soon as you remove the parent and child from the home situation, you're introducing, I guess, factors that can get in the way and that might make it more difficult to implement any changes that are learned back in that home environment. So yeah, I think the one-on-one and home-based programs have an advantage, and probably that's why they are more effective with the more high needs families who require that level of intensity. I think the coaching component, I think, is also something that some families absolutely need. So um, the ABC approach and the PCITT approach to have that live coaching of parent behaviour in the moment, I think can be really powerful for parents who need
mm.
that kind of very clear instruction
Yeah, like more in moment rather than, yeah,
than
because
reflection. Yeah,
it requires a lot of self-awareness and reflective thinking.
yeah, absolutely, absolutely.
We have some chats questions coming up in the chat. So Jody was wondering, did you measure any infant outcomes in your research?
Thanks, Jody. So we tried to. In addition to the using the composite caregiving questionnaire and the Edinburgh postnatal depression scale, which was our measure of depression symptoms, we also had an observational measure of parent-child interaction, and we had a narrative interview measure of caregiving representation. So a kind of deeper level um, look at that compared with what we could do with the CCQ. So I'm getting to the specific question. We're writing up the results of the narrative interview component, which will hopefully be published soon. But unfortunately, the observational measure that we chose to use, which was one that was kind of feasible, we thought we could learn it quickly and we could manage it in a 5-minute interaction. It turned out to be not not really suitable. It wasn't really rigorous enough for us to get good inter-rater reliability, etc. So that was where we measured infant outcomes, which was we didn't do any long-term follow-up, so it was just immediately post-intervention. So we were just looking at sort of the quality of the infant response to the parent in a free play situation. But so we got kind of, as much as we can trust the evidence, we got some indication of parent improvements, so reduced intrusiveness, but we didn't get indications of improvements in the infants. But all of what we found from that observational measure sort of needs to be taken with a grain of salt because it probably lacked validity as a measure. Sorry, long answer.
Marie, and as you said, kind of the measures we use need to tap into what the intervention was doing, and it's not always easy to do that.
Absolutely, absolutely.
We have another question coming from Bushra, um, asking, is there evidence of the efficacy of attachment-based programs as a proactive measure?
Very good question. So the example I gave you of the VIP program for infants at risk of autism that's being delivered as a kind of preventative, preemptive kind of intervention. And even though it's still early days, the early indicators are very positive. Now, that's obviously looking at a specific outcome in terms of diagnosis of autism spectrum disorder rather than the more usual targets of attachment-based interventions. I think one of the difficulties with measuring, I think there's a general difficulty with measuring the impact of programs that are run as a preventative, because there's no proof of, we don't have any way of measuring what would have happened otherwise for that particular cohort. So I think that's a major difficulty in terms of that kind of preventative work, particularly with something like COSP, which I think is best suited for that kind of universal delivery where you're not dealing with a particular at-risk population. So I think that's quite difficult. Some of the other ones, I guess some of the research of the other interventions that I have shown to you probably could be considered to be preventative. Often they are families that are at risk, but not necessarily where there's already disordered attachment relationships or disordered behaviour or something like that. So, yeah, I don't know exactly, but I think there is probably some indicators that the preventative approach is helpful, but it's really hard to prove that empirically.
Thanks, Anne-Marie. Any other questions? Feel free to unmute yourself as well.
I might jump in if no one else has a question. Fantastic research body, Anne-Marie. It's really great to hear about it, particularly across different cohorts and age groups as well. I did note that you mentioned fathers showed some similar patterns to mothers, and I wonder, just knowing my own research and some of the other researchers that I can see that are participants today that have tried to recruit fathers into their research, how much of an evidence base did you have for fathers to compare them to that of mothers? And did you find that it was harder? Did you find that, yeah, they were likely to engage at a particular age group with their with their children? Was it older children, toddlers, so on? I'd love to hear any information about that.
Thank you. Yes. So we had a very small number of fathers. I can't remember the exact numbers, but it was sort of certainly less than 10% of the cohort. And we ended up, when we were reporting the results of the study, we ended up not being able to include the fathers at all, because as it happened, fathers were only recruited into the intervention group, not the waitlist group. So we didn't have that comparison, unfortunately. So as is the case with everything to do with parenting, it seems fathers are vastly underrepresented in attachment research as well, attachment-based intervention research, and probably in attachment research generally. One of the barriers for us was the way we did our recruiting, which was through organisations that cater for parents but predominantly work with mothers. And so, we got the odd father who was attending one of these groups, but it just wasn't the main clientele of the organisations. And that's certainly an area for future development. We were glad that we got some fathers, and we were glad that we had enough data to see that they seem to have similar benefits. But there's so much more work to be done. And I don't know if PAFRA has done a session on recruiting fathers to research, but that would be a really useful, because I know there is some very helpful research about how targeted recruitment needs to be for fathers to respond.
It's certainly nice to hear that it's a universal issue while simultaneously isn't. We know that it's a universal issue, but great to know that at least there are similarities in the efficacy for fathers.
Yeah,
Thank you so much.
yeah, a little bit of comfort.
Um, okay, I think there are just a couple of thanks in the chat. Everyone saying it's a great presentation, really clear, really informative. If there's no more question, I'll just let everyone know that we'll upload the recording to the PAFRA website and YouTube channel in the next couple of days. And yeah, everyone, please join me to thank Emery again for a fantastic presentation and a great body of research. Thanks, Emery.
Thanks so much. Thanks, Sylvia. Thanks, Sarah. And thanks, everyone. Really enjoyed being here today. Thank you. Bye.
Thanks so much, Emery.
My pleasure. Thank you. Bye.